Welcome to the Eyecare Experts, Dr. Bell, Dr. Terrezza, and Dr. Montgomery. We're talking today about macular degeneration and protecting vision in general as we age, because there's different types of macular degeneration. We'll get in that, but certainly I think most people are familiar with age-related macular degeneration. And I will say we have had this topic at least 3 or 4 times. I think we've discussed it on various podcasts. But this is the first time where we've actually dived into this just being the main topic of conversation. And so it'll be nice for us to dive into it. Hopefully, drop some facts and some knowledge and just kind of what we experience and what we see day to day. And we see a lot of patients, so how, what to look for, what to experience. Does family history factor in? There's a lot of things we're going to go through, and hopefully it's helpful for you or someone you know or a family member, because certainly this and glaucoma are really the big 2 things we ask about as far as if there is some genetics or some family history of it. You want to just kind of start, I guess, as far as any...
Yeah, I want to. I'll say that age-related macular degeneration is the #1 cause of blindness in people over 55. And what's amazing is an old-timer like me that's been in practice a long time, AMD wasn't even in the top 100 back in the 70s. And it went from that lowly position to the #1 cause of blindness. That reason has not been, it's been studied, but it has not been, it's still mysterious. And there's no good explanation. There are 2 kinds of the disease. One where there's fluid involved, and that's called a wet macular degeneration, and one where it's dry, where there is no fluid, but you lose your vision nonetheless. The split is 85% dry, 15% wet. The 15% wet has an abundance of treatments, most involving injections, very few topical medications, and testing of the blood vessels because they leak fluid, and there's different types of enzymes in there that leak that cause the damage, and that gets complicated, and I don't want to get into that. But it's just come from nowhere, and now it's the #1 cause. So you will run across someone that has that, and it's important to get it, again, if you diagnose it early, you can keep it under better control.
Well, thank goodness 85% is dry, because that is the slower chronic progressing one versus wet.
That's right.
Wet can get devastating and take away the vision very, very quickly. I know for me and you at least, when we first graduated optometry school back then, there were supplements and vitamins, and we still have those available today, and they still work. Whether it's AREDS or Preservision. There's a number of them out there, but basically it's giving you lutein, zinc, beta carotene, zeaxanthin, kind of to help the pigment drop out to kind of nourish that area. And we talk about macular degeneration. What are we talking? We're talking about the macula of the back of the eye, and that's where the highest density of cones is. When you read or focus, that's your highest clarity of vision. And that's the reason macular degeneration can be so devastating, because it's taken away that central vision. We have other conditions such as, let's say, glaucoma or retinitis pigmentosa that starts by taking away the peripheral vision. But macular degeneration, again, is tough because of that central. And that's what most of us rely on to be able to read, to be able to drive, to be able to see in general, is that macular aphobia. And so it's important to know who's at risk. Do you have that family history? There's ways that I know, I'd say, I'm trying to think, maybe 20 years ago, we started swabbing, taking DNA, because patients would say, hey, my mom's got it or my grandma's got it. We can swab the DNA, and we can pretty much spit out the probabilities of what it is that you're going to actually have it. And to me, that's amazing.
The newest machine on that, which we have at the 2 of the offices at least, are these perceptual tests, and they're done in virtual reality, and they can detect this disease 2 years before the doctor can see it. And so these are covered by insurance, and we run those tests. There's very few in the area, I might add, but we do that when, first of all, it's covered by your medical insurance. Number 2, we do it when it's appropriate. So if you have a family history, or we see things in the eye from our scanners and our photos, that indicate you should have it, we do it hopefully that day.
Yeah, and there's several things that can put you at higher risk. One is just being Caucasian. Having light eyes and fair skin will put you at a higher risk for it. It's predominantly an age-related disease, so people over 50, but especially 65 and older, we see it really come out at that time. It also goes along with smoking, being a smoker, or having trouble with obesity as well. These all factor in to give you kind of a risk. So if you're in a high-risk category, that's something that would be good to know sooner rather than later.
Well, smoking is a big one. That's the one thing with a patient that's smoking. It's hard. I mean, I get all that, but the one thing that they could do that would put them at low risk, that's a big one. When we start seeing that in the back of the eye. Patients will ask a lot. I'll see patients, and I've seen them, let's say, for the last 5 years, and let's say they're 30, 40, 50 years of age, and they'll say, hey, I have family history, what do you think? And what I usually say to that is I don't see any signs at this point. The macula looks good. There's no pigment changes, no RPE changes, but you're not 100% out of the woods. I mean, maybe you're 80% out of the woods. Because a lot of times we will not see macular degeneration signs until that patient is late 50s, early 60s, late 60s. And so just because, you had an eye exam last year or 5 years ago and you're 30 and you're 40 and everything was great and nothing was wrong, doesn't mean it's always going to be the case. There's things that present later on, and this is one of those things, if it's age-related, it may not even present to your 60 years of age.
And there's protective things that people can do to be proactive. I know we have a big family history of it. Good nutrition, eating your leafy green vegetables, your high-quality fats like your fish oil and salmon, all those are very good. We got to get the nutrients from what we eat. You can also be proactive by having good UV protection, wearing sunglasses, hats when you're outside. There's also a whole range of products that we can build into the glasses with blue blockers that help stop high energy light from electronics, and that's supposed to be protective in the long run against macular degeneration. Things that weren't available to our elders, we can prevent it even if we don't see it yet, or help.
No doubt, no doubt. And since I've been practicing, there's been a lot of advances and changes, and we're doing things a lot differently now than when we first started. And I think for us in general is we're able to monitor a lot of these patients in-house. Just instead of go ahead and referring you to maybe a retinal specialist and them just kind of watching you, we have OCTs, we have Maculogic, we have tools available so we can watch it and monitor it. And if it's dry, maybe there is some progression or changes, but it's not to the point where it's affecting you or to the point where you need something done about it. And so in the old days, we just had an Amsler grid. Anybody with macular degeneration usually is familiar with an Amsler grid, where you can look at it and see if there's any boxes missing or any metamorphopsy or anything like that. But we now, beyond the Amsler grid, we have tools available where it's a patient where they can look into a machine, and then they can, it can kind of spit out data and let them know the slightest variation, and can even email us. So that's a home tool that we use, and you can kind of talk on that a little bit.
We were one of the first, and the program is called 4C. So when you see the early signs, you even need more monitoring, either daily or weekly, and that's not just feasible to go see an eye doctor when that's present. A firm out of Virginia has a home setup where you look into this every day and you take this 4-question visual test, and it's tested, it's done by computer and feeds into a big computer in Virginia, which then if it has an errant sign or one of those tests is positive for change, it will email my office and tell me about it, so then I'll get the patient in. But the odds of missing an event that has a time window on it, that is 2 or 3 days to have it treated, that won't happen. So the patient, when they get notified of that, and I get notified of that, my office makes them an appointment. If it is in fact something serious that requires surgical or intervention, which is most of what it is, then that's referred to a retinal specialist very quickly, as opposed to a month or 2 or 3 later when the damage has already occurred.
And you may be saying, why is it so important to know it that quick? Well, some of these patients may have already lost vision in one eye because they've already had wet macular degeneration, and it may be that second eye that we're watching very closely to hopefully prevent it from getting to the point because they only got one good eye to see out of at that point. So, it is critical to stay on top of this and watch it and make sure it doesn't turn wet or make sure it doesn't get to the point where we don't need to get you in to that specialist to whether it's an anti-VEGF injection or whatever the treatment is. We want to do that as soon as possible, not wait.
And those home machines and the testing all occur in your house. And they have a 1-800 number. They'll walk you through it and keep track of it, any problems you have. So it's no imposition on us and no charge to you.
Yeah, and most medical, to that point, most medical insurances are going to cover that because, heck, you've got macular degeneration, and that is a medical condition for the body and the eyes.
I think that's such a great option to have. I can't count the number of patients I've had come in and they've had a lot of vision loss in one eye and things have changed into that awful wet type that we hear about, and they didn't even know it was happening because the other eye was doing okay and it just took over, and so they didn't know in a timely fashion. With these home monitoring, it selects the eye for them. It is great for even people who are having some dementia and trouble who really can't tell us what they see. It'll help pick up on it.
That's correct.
Well, and that's, we always go back to this, but that's one reason, we, even if you see clearly year to year, we like to see patients for that full comprehensive exam. So we're looking at things. Every time we see a patient, we want to dilate you. We want to, do imaging, whether it's photos or anything to kind of watch these conditions. That way we can tell if something is changing, something's progressing. And I see a lot of glaucoma patients, but I always tell them I want to catch it before you ever even know it, before you lose that vision, because then if you're having that, you've lost vision that you'll never get back. And so by seeing us, we want to do all we can to hopefully slow it down, stop it, before it ever becomes an issue where you complain. That's what we're trying. Not all cases are that way, but we certainly try our best to make that outcome.
This disease is affecting the disability system. So the number of patients projected to go on disability could bankrupt Social Security. And they've already looked at this. That's why it's a critical enemy and it needs to be treated appropriately. Along those lines, some of the newest treatments, and they're already in Canada and they've been in Europe, and they use, it's called photobiology. And these red light treatments are used, and they're already certified in Canada by optometrists and ophthalmologists to project red light into the cells that are losing the fluids we talked about. And somehow the chemistry is complicated, that it stops the macular degeneration at the early dry stage and does not progress to the advanced wet stage. Those are not they're available at 2,400 sites right now in the United States. The closest one is in New Orleans. And the treatment is very expensive, is $2,400. But if it can stop that degeneration, that would be money well spent. But I suspect that once the initial company was bought by Alcon, which is a division of Novartis, the second largest drug company in the world. And they bought this technology this year and will prepare it only with the retinal specialists, but certainly within a year or two, will make it available to the average Joe practitioner, those being the primary care arm of the eye care in this country. And once that gets done to that point, I know that the volume will come down, the treatments will begin, and this disease will at least have a decrease, kind of like cancer does. You don't get rid of it, but you can cut the numbers down.
That's a good thing. Yeah. Well, and we have a great relationship with all the retinal specialists in the area, whether it be in South Alabama, whether it be in the Panhandle, whether it be in Navarre, Milton. We have great relations, and some of these things, like we said, hey, we can monitor this in-house, but when it gets to the point where, hey, it's turning wet, or hey, your vision is very decreased, or hey, you've got this or you got that, we certainly can get you to that retinal specialist based on the need, whether it be same day, whether it be the next day, whether it be a week. But that's the good thing I think about our practices, is the relationship we have, and we basically work together, send our notes back and forth, and then retina sometimes will clear you, or they'll do this or they'll do that, and then they'll get you back to us for what have you. And I know patients, we want to work together to make it as smooth as possible for you. And we want all patients to be educated on, hey, this is what we're doing, this is where you're going. You know, we usually give them papers, give them all the information, because we want to, you know, you want to know what's going on. I mean, whether it's us going for a dental appointment or what have you, we want there to be as little surprises, and let them feel comfortable with, you know, whatever the condition or wherever they're going.
Yeah, I think that's a good point. I think it's really important to have both the retinal specialist and the optometrist on board together. I have patients who I can see in the future that it's very likely they're going to need the help from a retinal specialist. And sometimes I'll go ahead and get them over there, let them meet the person, find out where the office is. And then if, heaven forbid, something happens, we're all ready to go. They're in the system. We can get them over, usually within a day or two, and they don't have to wait that month or two for an appointment if they went in and tried to just schedule the appointment themselves. So that relationship really helps us out on these problems that you have to handle quickly.
Well, I guess the big one I'm hearing about as far as commercials on television is gyrate atrophy, and certainly macular degeneration and affecting those things. So any condition you have, if there's come in and see us. If we can't take care of you, if we can't treat you in-house, we're going to get you referred or get you to that neurologist, retinal specialist, pediatric specialist, whatever specialist we need to get you to, whether it's a surgery, whether it's a procedure, we can get you to that person. So anything else we hadn't talked about them? You talked going through macular degeneration?
No, the options on care with the home care, the new treatment for dry.
Yep.
It's going to be a game changer, and I think people should stay tuned for that one.
Yeah, there's a lot of advances. So we appreciate you listening. Macular degeneration, certainly a lot, as you started with, there's a lot of patients that are affected, a lot more now than there was 50 or 100 years ago. Family history of it, certainly, come in. Let us know. Go to our website, give us a call. We want to help you in any way that we can. Thank you, Dr. Montgomery. Thank you, Dr. Terrezza, Dr. Bell. Thank you.
Appreciate it.